So good evening, everyone, and thanks for joining our November OTAC session today on the identification and management of QT prolongation with OAT clients, facilitated today by Dr. David Yu, who is an addiction medicine advanced trainee at Drug Health Services, SLHD. Next slide, please. So before we start, I'd like to begin today by acknowledging the Gadigal people, traditional custodians of the land on which I'm calling in from today, and recognize the traditional owners of the different lands where we are calling in from, and pay my respects to their elders past and present, and extend that respect to any Aboriginal and Torres Strait Islander people joining today. And next slide, please. So these are just the registration for tonight. Looks like there are a couple interstate people and from ACT, and almost half of the registrations are from the metropolitan LHDs. And the next slide. These are just some of the broad roles for who's registered tonight. A lot of general practitioners and pharmacists and a good amount of representation. So thank you for joining. And then the next slide. So the webinars, we use them as a mechanism to focus on specific topics related to OAT, and we encourage you to ask questions, interact with the polls, and submit cases, which you can do on the OTAC website. So please be sure to be on mute unless you're speaking or asking questions, and please feel free to make comments or ask questions at appropriate times. And if you do, it would be great if you also put your video on. We do record these webinars, so please try not to reveal any identifying information if you're speaking about a specific case. And if you feel like you have a conflict of interest, such as if you're a pharmaceutical company representative, we do ask that you please sign off, as these webinars are geared toward health professionals. And we will be having some case discussions today. We really encourage you to be involved in the cases through the online discussions or polls. So now I'd like to pass the mic over to David if you want to introduce yourself further.
Yeah, sure. So as mentioned before, well, first of all, thanks for having me. Hopefully this topic will be of interest, and hopefully I'll be able to show today that QT prolongation in the context of methadone is not that scary of a topic, and it's not that hard. I am a second-year addiction medicine advanced trainee at SLHD. Those of you who may know about the department, we also have a bit of clinical pharmacology and toxicology exposure as well. And prior to starting addiction medicine, I did some physician's training. But, even with those saying that, I'll have to admit that cardiology and ECG reading was not my favorite. And, I'm not coming from that sort of perspective, and I'm, not trying to make everyone sort of, ECG expert. And, during my previous training, I was quite heartened by the fact that a cardiologist once told me that reading ECGs is hard. But hopefully we're not here to sort of become overnight ECG experts. We're just focusing on the relevant aspects of how it impacts on OAT and specifically methadone. So the learning objectives that you can see here on the screen are to recognize and measure the QT interval in a 12-lead ECG. To also recognize how the effect and importance of OAT on the QT interval as is relevant to us as OAT prescribers. Also be aware and think about other medications that patients might be on that are associated in particular with a high risk of QT prolongation, and how to also how to assess safety in regards to QT prolongation, and how it impacts on starting and continuing OAT. And also to reflect on guidelines locally here in New South Wales, and also what other people have said, and how this impacts overall in our sort of risk assessment for the patient in total, not just regards to QT prolongation. So we've got a couple of polls to start us off with. The first one is, how confident are you in interpreting an ECG? Just want to sort of see what people's experience is out there. Jess, you might need to sort of guide me in terms of what people are saying.
I've tried to share the results. It looks like for the first question, how confident are you in interpreting an ECG? About 42% said somewhat confident and 50% said not confident.
Okay.
And then the
Yep.
second question, confidence in interpreting QT, about 43% said somewhat confident and 48% said not confident. So about the same for both.
Okay. Okay. So hopefully I can change that and give you a bit more confidence by the end of this talk. Thank you. Okay, so diving into our first case, these are all hypothetical sort of patients, but hopefully they'll be relevant or similar to patients you might come across. So first of all, Adam's a 28-year-old man. He's coming in seeing us in an outpatient setting, seeking initiation onto opioid agonist treatment. And essentially he already decided that he wants to try methadone. The reason why he feels like this is necessary, he used to work sort of as a laborer and recently was laid off work for the last 2 months due to a injury. And in that setting, he relapsed onto using heroin about 2 points a day. This is in the context of previously being on OAT. 3 years ago, he was incarcerated and he was on a buprenorphine depot. While it served its purpose, he didn't like it. He ceased it. As soon as he was released from jail, he never continued it. And for the up until 2 months ago, he had remained abstinent, but relapsed 2 months ago in the setting of losing his job. He has no past medical history, has no previous psychiatric history. He's on actually no regular medications. And he does not have a history of unexplained syncope, pre-syncope, or a family history of unexplained sudden cardiac death. When he first started using heroin at the age of 20, he had an overdose, but since then, he hasn't had an overdose in the past or more recently. But he's coming in seeing you because he wants to try methadone. So hypothetically, let's say you have the ability to do an ECG and you do a 12-lead ECG, and this is his ECG. We'll come back to this. But just a bit of revision about the ECG complex as a whole. So this is a graphic I've sort of borrowed from an article, an Australian Prescriber Review article, that if you're interested in, we'll give you the reference at the end. But this is what a typical ECG complex might look like. So there's a P wave, which is atrial depolarization. And then there's QRS, which is the ventricular depolarization, and then the T wave, which is ventricular repolarization. So the QT interval starts from the beginning of the QRS complex, as you can sort of see here. Can people see my mouse? It starts at the beginning of the QRS complex and then goes to the end of the T wave. So that's the QT intervals from the start of the Q to the end of the T. And in total, the QT reflects depolarization and repolarization of the ventricle. Just going to make a small note about the J point, and there's a JT interval which is looking really just at ventricular repolarization, and in a small number of cases that might be sort of more reflective and more important to look at. But in general, we talk about QT as being the thing that sort of we care about. And what is a normal QT interval? It depends, but in general, it's said to be less than 450 milliseconds or less. Depending on the reference that you look at, they might say that for males, it's less than 440. For females, it's less than 460. But if you want to just remember one number, 450 is okay. And above 500 is where you start to really get sort of worried at, oh, this is not just slightly abnormal, it's quite abnormal, and that may or may not change what you do. But we'll come back to that. There's also this thing about QT and QTC. And so there's 5 equations here, and not going to go through them, but just to show that there's multiple. And the fact that there's 5 means that no one probably gets it particularly right, and everyone sort of disagrees. But essentially, we care mostly about the QT. That because that correlates best to sort of the risk of torsades, which we'll sort of come back to. But in the literature, people might interchangeably say QT or QTC. QTC is a sort of correction because the QT interval does depend on the heart rate. And essentially the formulas are trying to normalize the QT to what if the heart rate is 60. So if the patient's heart rate's higher or lower, if the patient's heart rate was 60, what would the QT be? So that's what the purpose of the QT or the spirit of the QTC formulas are. But there's a few, and essentially we don't care too much about them. Okay, so wasn't sure whether I was going to sort of bring this up, but essentially the most important part is sort of phase 3. So within a sort of ECG complex and within the cardiac cycle, there's multiple channels where ions go up and down. But essentially the most important part for us is this one, which is the delayed rectifier potassium channel. So after the ventricle depolarizes, as it's repolarizing, potassium flows from the leaks out slowly in a delayed fashion from the intracellular compartment back to the extracellular compartment to go back down to a resting membrane potential. And this is where methadone can, or and a lot of medications that prolong QT block or inhibit this channel, and it's also sometimes known as the hERG channel or the human ethero-go-go-related gene channel. And methadone and other medications can bind to a specific subunit inside this channel and actually delay potassium from leaking back out of the cardiac cells. And if this happens, there is a risk, for causing long QT, and there is a risk for the subsequent thing happening. So why we're even talking about this at all is that there is this rare clinical entity called torsade de pointe, or twisting of the point in French, or also otherwise known as polymorphic VT. So this ECG that I've taken from a case report, it's probably not the best example, but hopefully I can impress on you that instead of all the sort of the QRS complexes are broad. You can't make out or see any P waves or T waves, but you can see that the height and the shape of the QRS complexes are changing. The heights are changing, and essentially what it's supposed to be is like waxing and waning, sort of the height sort of changing, and the axis is sort of changing. And so it's called sort of polymorphic VT, whereas monomorphic VT, you essentially see the same thing for the whole rhythm strip. Yeah. In general, torsades or polymorphic VT is, rather brief. It's usually self-limiting, self-terminating. By itself, if it goes away, you don't need to treat it specifically. But if it causes hemodynamic instability or if the patient arrests, this is a shockable rhythm. So if they are conscious and they have a pulse, some things you might do is you might give IV magnesium or try to find out the cause and treat the cause and remove the cause if that's practical and possible, and having the paddles on them to shock them if they were to lose consciousness. Sometimes if torsades is sustained for a prolonged period of time, it could degenerate into ventricular fibrillation, which is by definition pulseless and is also a shockable rhythm. This is something you hope to never see, and something we're all, I think, vaguely aware of and scared of. But fortunately, it's very, very rare. Okay, so going back to sort of the QT interval, we sort of know where it is on the ECG complex, but how do we measure it? So I guess one of the first sort of pitfalls is if you do an 12-lead ECG on a patient, often we have the tendency to look in the top left-hand corner what the machine says. So the first thing to do or to be aware of is that the machine can actually, it tries, but it can actually sort of make mistakes, and it can actually give you a false reading. So don't trust the number in the top left-hand corner of your 12-lead ECG readout. So if you can't trust the machine, or you're not sure if the machine's actually sort of picking up the right intervals, you need to be accurate. You need to sort of measure it manually, and this sounds like it's a lot of work, but it's actually not if you sort of get used to sort of doing it. You don't want to just pick one ECG complex, because the QT, first of all, can change beat to beat, but also depending on where your leads are and how things are sort of pointed, it can actually be quite hard to sort of measure, or quite hard to figure out where does the QRS actually start and where does the T wave actually end. So rather than just picking one randomly to get a sort of more sort of accurate measurement, what you want to do is you want to pick QRS or ECG complexes in multiple leads. And there's and the Australian Prescribe article that we sort of reference recommends choosing 6 ECG complexes in 6 different leads. They recommend 1, 2 AVF, and then 3 chest leads, V2, V4, V6. And when we get back to the ECG and we show an example, you'll sort of see why some other leads, it's not so easy to actually measure the QT interval in. In terms of how to sort of measure manually, there's a few different ways, but the method that I like, and it's quite reliable and I was taught, was the tangent method. So you can see on the right-hand side of the screen here, you take the steepest part of the downslope of the T wave and draw a tangent from the steepest part, and then see where that intersects on the isoelectric line. And even if there is a U wave, and if the U wave merges into it significantly, there's a way to sort of deal with that. But the intersection point of the steepest angle and the isoelectric line, or the baseline, is probably where you should put the QT interval. And depending on whether the T wave sort of is steep and goes down, or whether it sort of flattens out a bit, may actually not, the point where you sort of think that measure the QT interval as being the end may actually not be where the T wave appears to end. So it can be sort of slightly subjective, but using a consistent method of using a tangent may sort of decrease or remove the sort of variability and subjectivity into where does the QT actually end. And then you take 6 and you take the median, which is the average of the third and fourth. So going back to Adam's 12-lead ECG, I've got an example here. So for us, you may have sort of clinic software or electronic software like we do, but we've got sort of calipers that we can sort of measure distances on the ECG down to sort of millisecond lengths. Just ignore the sort of second number here. That's sort of not relevant. That's more relevant if you were to sort of measure the RR interval to get the heart rate. But here we've got, lead 1, lead 2, lead AVF. And you can see that AVR in general is always, everything's always flipped, everything's negative, and V1 is often sort of negative and flipped. So it's actually quite hard to try and figure out where the tangent should be for AVR. And so AVR is probably not a good one lead to choose to try and measure this in. Same with AVL, it can look a bit funny. But in terms of the axial leads, so out of these 6, 1, 2, and 3, and also AVF are reasonably good ones to sort of pick from. Usually because if you remember the sort of cardiac axis being sort of between minus 30 and 90 degrees, it's usually along or similar to the direction of the leads of 1, 2, and AVF. If you remember that, if that's a bit too much, that's okay. It's not important. And so I've measured 6 of these here, and I've sort of put them in ascending order. So from lowest to highest, And fortunately for us, the two middle numbers are 325 milliseconds, and the average of 325 and 325 is 325. So Adam's QT interval, the raw QT interval, not the corrected one, on this 12-lead ECG today is 325 milliseconds. So if you remember back to 450 or 440 being the cutoff of what's considered normal, this is well within the sort of normal range, and sort of what we would expect. For young, healthy people who otherwise don't have pre-existing cardiac conditions or rare channelopathies. So the third poll, and I've sort of, I guess, already sort of given you some hints, or, must Adam have an ECG prior to commencing OAT? I know we've just done an ECG in this hypothetical scenario because it's hard to have a talk about QT without doing an ECG, but is it important? Is it essential to have an ECG?
We've got about 50% voted. I'll probably wait a couple more seconds and see if more people will vote.
Are you seeing
Okay.
the chat, David?
No, sorry.
Oh, it's just Urmila's just asking, do ECG machines usually calculate the median QT interval so that you don't have to calculate this value yourself?
Good question. I don't know exactly how the ECG machine recognizes it. Essentially, I'm advocating for you to ignore the machine and to measure it yourself. I think in most cases the machine might do a reasonable approximation, but the most accurate. Yeah, okay. Looks like people have said no, but it would be nice. Good, and no one's sort of taking my tongue-in-cheek sort of last option. We'll get back to it. It might be relevant, but we'll come back to sort of what different people have to say about this issue. Okay, so just finishing off the case. So you do the ECG in this case, and his QT was normal. You start him on a sort of reasonable dose of methadone 30, and you allow him to escalate as per standard guidelines. And when you review him 2 months later, he's stabilized on 80 milligrams. We don't have another poll for this, but just sort of think of this as a rhetorical question, which we might come back to if we have time. Should you repeat an ECG? And if so, when, at what dose, or at what time point? Just sort of think about that. So different people have different things to say about that. So moving on to case 2.
David, just
Bernard,
interrupting. So Dan's asking, what I really want to know is which patient routinely should have an ECG prior to opioid treatment if no family history of sudden death and no concurrent meds known to QT prolongation of risk. But I think you're going to answer that as you progress, aren't you?
yes. Yeah. So
maybe we'll just pause in responding to that and go back to it if necessary.
Yeah, so we're going to hopefully over the rest of the talk, I will address it. If not, we can sort of come back to it at the end.
Yeah.
It's a question. You're very precise. How should we measure the QT as accurately as possible without calipers? So if you have the traditional ECG paper printout, you can fall back on the tried and true method of small box being 40 milliseconds and a large box or 5 small boxes being 200 milliseconds. I think the single digit millisecond accuracy is nice if you have that ability, but I don't think it's necessary. Case 2, Bernadette. Okay. So Bernadette is a 45-year-old female. She's been on methadone for the last 18 months. Her dose up until now, or her stable dose historically, has been 90 milligrams. She has a past medical history of hypothyroidism, depression, and also opioid use disorder. Unfortunately for Bernadette, she's come and attended for a routine outpatient OTP review, but she discloses that she's had to leave her usual residence because she's been a victim of domestic violence, and she's been living in a women's shelter for the last 2 weeks. Also because, hygiene and food has not been the best. She's also contracted a bit of self-limiting gastroenteritis, and she's had pretty bad diarrhea for the last 5 days, but that's resolving. And that's why she's able to come and see you as an outpatient. In this sort of setting, she's lapsed and used heroin once in the last week and had a few doses of low-dose street diazepam, but not daily. Again, because we're doing a talk about ECGs, you hypothetically, let's say you do an ECG and the QT is 475 milliseconds. Remembering that 450 or up to 460 might be considered within the normal range for a female. So, based on Bernadette's case and the information provided so far, would you reduce a methadone dose? The next poll.
We've got about 30% who voted so far, so I'll probably give it another 20, 30 seconds to see.
Mm-hmm. Okay, all right. Good. So 32% said that you would reduce it because they're worried about the risk of torsades. 45 has said no, they're more worried about the risk of accidental overdose, given that she's lapsed and sounds like she's mentally, emotionally not in an ideal state. And a few people, 23%, have said they would switch her to buprenorphine. Okay, we'll come back to that. Okay, so we're going to talk about sort of the conditions or causes of long QT other than medications. So of course there are rare cardiac channelopathies, so congenital causes of long QT. So I think a lot of potassium channelopathies are grouped together as Romano-Ward syndrome. I think we've now, since it's been described, we've found that there's multiple underlying genetic channelopathies, but these are sort of quite rare. And in terms of, and it's sort of not, and then if you're moving away from congenital long QT syndromes, there are several conditions, and it's not entirely clear who is at risk or is not at risk, but some conditions that are known to be associated with long QT is being of female gender, is also of being of older age, electrolyte abnormalities, so hypokalemia, hypomagnesemia, or hypocalcemia can all contribute and cause long QT if they're severe enough. Hypoglycemia as well. And also previous cardiac issues. So ischemic heart disease can give you acquired conduction defects in the heart, which might put you at increased risk of arrhythmias. Cardiomyopathies, again, similarly, if there's structural heart disease that can cause issues. And also hypothyroidism. There's also a list of some medications, some drugs, which we will come back to, but that's more relevant to case 3. So we'll come back to that. So you do some tests on Bernadette. So given the history of diarrhea, you do some blood tests, and her potassium is 3.0, her magnesium level is 0.6, so a little bit below normal. And you also do a TFTs, and she comes back as being slightly subclinical hypothyroidism or hypothyroid, depending on your reference range. T4 10 is about towards the lower end or slightly lower than normal. And clinically, she's quite upset and a bit bruised, and because of the chaotic situation in which she had to sort of leave her previous residence, she was not able to take her medications with her, so she's been not taking her thyroxine and her antidepressant as well. And the sort of sort of substance use that she sort of reports to you is due as she reports as a coping mechanism due to the trauma that she's experienced. Importantly, she doesn't report a history of pre-syncope, syncope, or palpitations in the last sort of 2 weeks or prior to that. And so you have a sort of discussion with her. You inform her of the risk that her QT is slightly longer than it should be. It's slightly above the reference range, and there is a risk. There's a low risk. But there is an association of this very rare complication called torsades. And you have a discussion about the risks, and but also include the risk of, in her current situation, there's a risk she may use. You warn her about the risk of overdose, and she sort of requests you not to reduce the dose, and so you decide to give her replacement with oral supplements with potassium, magnesium, restart her usual medications, her thyroxine, and to sort of follow up in 1 week. That's sort of one way that the scenario might play out. Moving on to case 3. Are there any questions in particular about that case?
Not currently in
Okay.
the chat. Not currently in the chat, David.
Okay. Yeah. I think that question was, yeah. So shared decision making is an integral part of risk and benefits and discussions about what we sort of do. So I deliberately didn't sort of give you certain information on the first slide and gave you a poll. So it's an unfair question, but just wanted to see what people thought. So moving on to case 3.
Marguerite's in the chat. Marguerite's just asked, what would you do if she did ask for an increase in her dose?
Yeah, that's a good question. I think it depends on how important sort of it is to her. I mean, I think you try to sort of persuade her against it, but if she was sort of fixated, I think it's something that you could consider. But you'd have to sort of say, we really need to monitor closely. Ideally, you optimize the treatable, modifiable sort of things like mild hypokalemia and hypomagnesemia and hypothyroidism, which may be impacting on it first. So you could potentially say, is it okay if we do these things and then revisit it in a week? And she might say yes or no. And but I don't think it's unreasonable. It's not certainly at a dose where you would have to go, no, we absolutely have to stop. You're going to drop dead. I think that would be probably, sort of putting too much weight on that risk.
Yeah, and so Angela's just pointing out that she's also on a benzo.
Yeah. Do you want to clarify that? I think I threw in the benzo to sort of say diazepam is not a QT prolonging sort of drug. Of course, we are concerned about polysedative overdose risk.
Yeah. I mean, if Angela wants to unmute herself and clarify, or Angela says she would not increase the dose.
Yeah. That depends on, I guess, the patient's insight and what they say that they're going to do regarding the benzos. If they said, "Oh, that was only for last week, but I'm not going to use it again," I think it depends on a few things which you'd explore further, which I did not provide or go into in this hypothetical case. Okay, moving on to the third case. So Casey's a 24-year-old female. You're again reviewing her in an outpatient setting, and you're reviewing her post recent discharge from hospital. She's been in hospital for about a week. She's got a history of complex PTSD, depression, and also opioid and benzo use disorder. The discharge summary and what the discharge summary says, and what also the patient tells you, is that she was upset and took an impulsive overdose of 1 gram of citalopram and 100 milligrams of diazepam. She had to be admitted to ICU for a period for 2 reasons. She was quite sedated due to the diazepam, as well as being on a therapeutic dose of methadone. And also, the ICU doctors were quite concerned that she had developed long QT for up to 560 milliseconds at the peak. And so they had on telemetry and they were keeping a very close eye on that. She didn't develop torsades, but she was in ICU for a while and they were keeping an eye on it. Part of her treatment in hospital, the hospital doctors reduced her methadone from 80 to 40. And the patient was discharged, or you got a call saying, we've reduced the dose to 40. Please write another script for the patient. And so the patient's come and seen you. And so also as part of the sort of discharge summary or what happened in hospital, they stopped her citalopram. And there's a recommendation that you potentially you should consider switching it. And the patient is still a bit better, not sort of impulsive, not suicidal at the moment, but reporting withdrawals and cravings and requesting to increase her methadone dose. So how would you manage cases? Oh, and if it wasn't sort of clear, the ECG was monitored. Her QT is not currently 560. It came back, it normalized, it returned to normal, at which point she was taken off telemetry, she was discharged from ICU. She spent 4 or 5 days in the psych unit, and then she was eventually sort of discharged with a normal QT interval. So now in this setting, in this hypothetical setting, how would you manage Casey's opioid cravings? I think this is the last poll for the day.
David, could you just click your slide again? It's got a duplicate on the screen.
Oh, okay.
Go back again. It's sort of, I don't know why it's doing that.
Oh, okay.
Yeah.
Are people not seeing the poll?
That's better now.
Okay.
Yeah, it was just like there were two slides at once for some reason.
Okay.
I have no idea why. No.
Yeah, not sure. Okay.
No, it's better now. That's good.
Yeah, good. Okay. Do you want to, or should I just talk, sort of explain the polls? So yeah, 36% said increase methadone, 9% said no change, too risky to go up. 32% said switch to buprenorphine, and 23% said not sure. So about even numbers of people who would say either increase the methadone or say switch to buprenorphine. Okay. Yeah, so so there are, unfortunately, there's a lot of drugs out there who, if you look at the black box warning or the product information, which says that there is a risk of QT prolongation, but they don't necessarily quantify, and it's kind of vague. Fortunately, the list of medications that are high risk of QT prolongation and high risk of torsades is much shorter. This is, again, copied from an Australian prescriber article, but some representative medications which we're quite concerned about are not all, but some of the SSRIs, so citalopram and escitalopram, it's S enantiomer, clobamide, which is a MAO-B inhibitor, which, I think it's still might be used. TCAs, that's a bit of a funny one. So we did mention, or I mentioned the JT interval. TCAs technically cause the QT to appear longer because it can cause QRS widening, but it actually doesn't cause JT widening. So tricyclic antidepressants is not really a risk factor for torsades, but if you want to be pedantic about it, may make your QT look a little bit longer, even on therapeutic doses, or certainly an overdose. Lithium's a bit of a funny one. I think it can rarely cause QT prolongation. There's some antihistamines that can cause it as well. And there's a long list of antimicrobials that can cause it. And a few of these sort of older antipsychotics, not all, but there's a particular few that are sort of quite well known, which still we do see occasionally. So amisulpride, chlorpromazine, haloperidol. people who might have come across droperidol, I think that one's notoriously has a black box warning saying, causes QT prolongation, but it's actually much less QT prolonging and much safer than haloperidol. Long QT doesn't equal torsades, and it's actually more complicated and probably outside the scope of today's talk. But there's a few weird medications, such as amiodarone, that does actually cause QT prolongation, but it actually blocks multiple sort of channels. And actually, of the sort of antiarrhythmics, is probably one of the safest. And actually, amiodarone is known to not really cause torsades, despite causing QT prolongation. So it's actually more complicated. And cisapride is a medication we don't really see often, but I think that's reasonably well known, and methadone as well. In general, when drugs are developed and coming through the drug development pipeline, medications or drugs that are high risk for causing torsades essentially never sort of make it out the other end. So there's a short list of reasonably sort of old medications, of which methadone is one, and plays a very important role still, that we're sort of left with. So in general, there aren't sort of tons and tons of new and wonderful drugs that are coming out that we need to be scared of. And the list that we're particularly concerned about is quite short. This is a list. This is not the only list, but there's a few similar lists out there. And if you want to sort of go down a rabbit hole, there's a long list of medications which so a better way to sort of assess risk of torsades is using this QT nomogram. If you have the uncorrected QT and also the heart rate, you can plot it on this nomogram. If you fall below the graph, you're fine. You're essentially not at risk of developing torsades. If you're above the line, you are at some risk of developing torsades, but it's not like a guarantee or 100%. The risk is there, and it's usually still quite low, as we'll sort of show with examples. And the QT nomogram is not a be-all and end-all. It really depends on the medication that you're talking about. Just a sort of little point, there's a dotted line here, which is an extrapolation, but essentially, when you're sort of beyond a certain heart rate, you essentially won't get torsades. And in fact, the treatment of long QT and torsades, or risk of, you've got long QT and you're at risk of developing torsades again. If you're bradycardic or you've got a normal heart rate, one of the treatments is actually to drive your heart rate above 90. But that's sort of fine print. This is an example of a few medications or different drugs where people in an overdose setting, what can cause or doesn't cause sort of torsades. So these individual dots are QT and heart rate pairs from patients who take a bunch of non-cardiac drug overdoses. So for example, diazepam or paracetamol. Quetiapine, I think, has a warning of potentially causing torsades, but it's a bit of a mistake. Essentially, nobody who takes a quetiapine overdose ever develops torsades. And if you were to plot them on this graph, you can sort of see most of them fall below. And even there are a few which seem to be above, but I don't think we've ever really heard of a case. Citalopram, one of the medication I chose for this case. Yeah, so citalopram certainly, depending on the dose or depending on the person, depending on the situation, can cause quite long QT, 550 or even getting close to 600. So it is known to do that, and it's sort of dose dependent. In general, it's at therapeutic doses, it's still reasonably a safe medication to take. So I'm not telling you to go and de-prescribe everyone off citalopram. That's certainly not the message of this talk. But amisulpride, which is known, sort of these little sort of blue X's are the cases where torsades did occur. And as you can see, people who are just above the line, there's still plenty of people who are just above the line who don't immediately go into torsades. And there's actually people, strangely, for, I guess, other unknown reasons, have an even longer QT who didn't develop torsades. So it's not the QT nomogram is probably not the be-all and end-all, but it is a risk assessment tool that you can use, and emergency departments and toxicology departments may choose to use. But getting back to sort of, I guess, medications or drugs that we're more familiar with prescribing, this is another slide from another sort of paper. The reference will be available at the end. There was an interesting study from a group up in Newcastle who got a bunch of people on either buprenorphine or methadone for OAT, and also a bunch of healthy volunteers, and actually just got them to wear a Holter monitor for 24 hours and actually just looked at what happened to them. Nobody developed torsades, nobody fainted. But the controls all lie sort of under here, as you would expect. In this small cohort, I think they had about 20 people. Yeah, 20 people on bupe. Everyone was under the nomogram. In the methadone cohort, there's a fair number of sort of these sort of like open circles, which are maybe a bit hard to see. There's quite a few people who are actually sort of above the nomogram at various points in time. And the Holter monitor sort of takes sort of like an hourly QT heart rate pair. So you might get about 24 or slightly more, slightly less sort of data points per patient. But there's not an insignificant amount of points above the line, which might sort of scare you a bit. But none of these people sort of torsades or syncope or had unexplained syncope, or sort of essentially nobody dropped dead. So I think depending on whether you do an ECG or a Holter monitor, you might sort of pick up or detect more transient long QT. But we actually know from a long period of time of people being on methadone for years and decades that torsades is actually and due to methadone is actually a very, very rare complication. Just touching or sort of showing you an update from the FDA about their sort of labeling about buprenorphine. So I think if you look at old sources and our sort of guidelines, they do sort of say, oh, buprenorphine might cause QT prolongation. I think there's been an update recently to say, yes, buprenorphine may cause QT prolongation up to 15 milliseconds, but there's been thorough studies of this. And despite most drug-induced long QT being mediated through hERG channel blockade, QT prolongation that is due to buprenorphine does not seem to be mediated by the same effect. We don't know how it happens, but it's there, it's real, but it's really tiny. It's less than 15 milliseconds. To just put that into context, anything less than 10 milliseconds of QT prolongation is just not significant. So it's barely real. And so the FDA has sort of revised their product labeling to say buprenorphine is unlikely to be proarrhythmic, but they also hedge and say if the patient's on multiple QT prolonging agents, we're not going to comment, and think about other causes and look for those and consider that. So they're not going to sort of give you a blank check, but essentially they're saying buprenorphine doesn't really cause long QT. So going back to the case, so yeah, okay, you do an ECG because the history and the QT is confirmed to be normal at 410. You're concerned about the patient, you have a discussion with the patient about the QT but also polysedative overdose risk. Hypothetically in this situation, the patient agrees to switch to buprenorphine due to various benefits it might offer. And I know that's washing over and simplifying it. And also you decide to switch her citalopram to another antidepressant and trial that and follow up and see how that goes. Now, when should you do an ECG? So I think we sort of commented on this much before. So this is a clinical guidelines released by an American group, which says some reasonable things, but point 3 can be quite controversial. So clinicians should inform patients of arrhythmia risk when they prescribe methadone. I think that sounds reasonable. Clinicians should ask patients about any history of structural heart disease, arrhythmia, and syncope. That sounds reasonable. This is the point which I think caused a lot of backlash and anger and angst. So they recommended that people should, like everyone should have an ECG for all patients to measure the QT, and also follow up and do one in 30 days and annually, and also do it again if the dose exceeds 100, or if there's a clinical indication, if the patient has syncope or seizures. That last bit's probably reasonable. There was a lot of backlash, and because I think we work in a different environment to the Americans, there was a lot of people who sort of wrote angry letters to the editor saying, no, if you insist on an ECG, if the patient doesn't have an ECG and we don't prescribe methadone, a lot of people are going to die because you delay treatment. And so I think the group later revised or sort of pulled back on that statement. This last part, next two parts sound reasonable. If the QT interval is greater than 450, but between 450 and 500, you should discuss the patients, the pros and cons. You should monitor more frequently, treat anything that's modifiable. If the QT is greater than 500, you should consider just reducing or discontinuing the methadone dose, but also do a medication review and treat anything that's reversible. And also, if there's any potential drug-drug interactions, you should be aware of. You should be aware of drug-drug interactions and not put the patient on multiple medications that can cause QT prolongation, or something that might increase or decrease the clearance of methadone. So just some quotes from the angry letters to the editor. So, someone, I think from Australia, quoted that over 30 years, people were on methadone, and there's only 43 cases of torsades reported to the FDA. And even in the few cases that there were, there were other causes. It wasn't just the methadone. They had hypokalemia or something else, which contributed in sort of to them developing torsades. And someone else quoted that, OAT reduces the high mortality in the addiction population by approximately 75%. So taking that into context, this shouldn't stop you from putting people onto OAT, and saying that an ECG must be done is going to cause more harm. Just briefly in the last couple of minutes, what do our guidelines say? I think our guidelines take a more balanced approach. So this is a section from the New South Wales OTP guidelines. So first thing they say is there's limited role for routine ECG. So you don't need to do an ECG on everyone for patients seeking to commence methadone, because that can lead to delays, or if they refuse an ECG, or they never start, that can cause a lot of harm. However, for patients who have a previous history of QT prolongation for any reason, patients who may report symptoms which may be clinically consistent with an arrhythmia, so unexplained syncope, palpitations, dizziness, you would want to do an ECG. It's no longer a screening test at that point. You're trying to look in for the causes of these symptoms, or if they have any other significant risk factors for QT prolongations, a list of medical conditions or medications which may cause QT prolongation. You might want to do an ECG, and it'd be more important to do that as part of your global overall risk management strategy. Patients should be informed of the risks, but they should be informed, but you shouldn't sort of catastrophize it and overplay it. You don't want to sort of scare people or discourage people from methadone. Methadone is still a valid sort of OAT option that we have and that we still use, and it still does a lot of good when used appropriately and monitored appropriately. And so you shouldn't delay starting someone just because they can't, or you can't, or they're not able, they're not willing to do an ECG. And you can sort of cause harm. There's a sort of section below this, which is in sort of screenshot, but I think our guidelines says consider doing an ECG if you're above or considering going above 120 milligrams per day. Final thoughts. So take-home messages. Methadone can cause QT prolongation. Try and avoid QT prolonging drugs if you can. An ECG can be useful, especially if there's risk factors or possible symptoms, but you shouldn't refuse to put someone on treatment, I think, just because you can't get an ECG or the patient's not able to or willing to do an ECG. The best way to sort of measure the QT would be to do it manually. And, hopefully, I've shown you it's probably not that hard. And of course, you should take a shared decision-making approach in discussing what to do regarding OAT medications, whether it's methadone or buprenorphine, and the dose, and what you do, as always, to sort of lead to good outcomes. This is so the Australian Prescriber article I've borrowed heavily from. If you want to sort of revise it or go back and read it, and this is quite easily searchable. A lot of the screen grabs are from there. For extra reading, if you're interested, the same, I think, group also did the Holter monitoring, and this is an interesting read. Don't know if it's going to help you or cause you more anxiety. And that's it. Sorry, I think, okay.
Thanks,
7.
thanks a lot, David. I don't know if you could see the chat. There's just a couple of last questions.
We've got time for a few questions.
Yeah, Gabriel Penn has written something in there. Can you read it?
Yeah, where does the nomogram come into consideration here? These guidelines seem based on absolute values of QT, so I'm not sure about or the role of the nomogram. The nomogram is probably not ideally something that you're going to want to use or routinely use in the outpatient sort of routine sort of setting. This is probably more for people who may also work in ED or may work in a sort of toxicology setting. Yeah. Yeah, sure. I'm happy for my slides to be sent if people are interested.
Yeah, that's great, David. I think they'll probably also end up on the OTAC website somewhere.
Yes, we
Yeah,
will be sending the slides out and putting them on the OTAC website after this.
and you'll be uploading the recording as well. So if you want to
Yes.
listen to this all again,
I'm
um,
really inspired to get my little rulers out and that improving my QT measurement.
yeah, once you get into the habit of doing it, it's not actually sort of that hard. And even if you don't do 6, at least if you do a few, you'll, as you could see, that they're all reasonably close to each other. So you don't necessarily have to do everything by the book that Jeff Isbister says, but that's his article and that's his recommendation, and that's kind of the way I was taught as well.
Yeah, Janelle says she's very interested in following your suggestions, Reid QT.
Oh, thank you. Gabriella, did I answer your question adequately? I'm not sure if I did.
Sorry, I'm just on my phone. Yeah, you did. I guess because I work in an outpatient OAT clinic, and I guess yeah, I find it difficult to know what to do because you read the guidelines and it will tell you to, I guess, change management based on the QT interval. But then if I speak to like I guess specialists, they tend to be more interested in the nomogram. So I guess I was just not quite sure which way to go with that when yeah.
Yeah. I think it plays a role, and I think it helps you sort of refine your sort of risk. So rather than just look at the QT, as you remember from the nomogram, it depends on both the QT and the heart rate. There was a sort of flat, so if you're bradycardic and your QT is a bit prolonged, that's sort of higher risk. So if your QT is 500, regardless of what your heart rate is, your risk is not 0. But just because you're slightly above the line doesn't mean immediately you're going to go into torsades to the next heartbeat and you're going to die. That's, I guess, our fear, or sort of us sort of catastrophizing or sort of wondering what might happen, but it's part. There is a risk, but I think based on the longitudinal data of people being on methadone for 30 plus years, if not longer, the fact that it's still at least in case report or case series territory, or reporting serious adverse effects to a sort of regulatory body in a different country, that sort of gives you a rough idea of how rare exactly this is. So I think it still needs to be taken into the context of the patient as a whole. And if the patient says, please don't decrease my methadone, I'm still using, or I might use, and you might go, yeah, I'm more worried about you dying of an overdose. I think you can't just insist, and having a shared discussion and informing the patients and figuring out what risk is more material and what risk is higher in that patient in that particular scenario, I think is a balanced way to sort of approach things.
Thank you, David. If you could just go back to the last slide with the opioid treatment guidelines. And also, again, the slides will be available online and the recording. We'll put that up tomorrow. I just want to thank David and everyone for sticking with us through the technical difficulties. Oh, can you go to the
Oh,
third from
the
last
end?
slide. So we have resources like the New South Wales OTB guidelines, and then also on this slide, we have support services and other services that you can access like SafeScript, New South Wales, and DASS, as well as your local alcohol and other drug services. You can scan the code or click the link, but we'll also send out the slides, so there's no rush to do that. And on the last slide, we want to thank you for your contributions, and especially big thanks to Dr. David Yu for his presentation. Our next presentation will be on planning for holidays for prescribers and clients and provisions for unexpected leave, presented by Professor Paul Haber on December 5th at 6 p.m. If you have any questions or suggestions for topics or cases, please feel free to send them to the OTAC email, and we will be uploading this webinar once again. Thank you for coming today.
Thank you for your questions and your kind comments, everyone.
Thanks very much, everybody. And thank you very much, David. That's a great presentation. Much appreciated.